Thank you for joining us today. This is a recording of a slide deck presented during a webinar on November 14th, 2024, hosted by the Analytics and Research team at CNO. This presentation will discuss collecting, reporting, and utilizing identity-based data. My name is April L, and I am the project lead on the Workforce Census. To start off, I want to acknowledge that we are not experts in this. We're still learning ourselves, but we are sharing our process and learnings in hopes that when you embark on your own data collection journey, you'll feel slightly more prepared. If and when you've gone through a similar process in the future, we would love to learn from you too. I will be reviewing the key steps taken, the challenges faced, and then Niels will walk through our findings. The first thing we did was an internal consultation with the leadership team within the college for insights around the why, the what, and the how. We recognized the value of doing this work within our team, but we wanted buy-in and input from across the college. Focus groups are set out to answer 3 questions from a quality improvement lens. First, the why. How can we use this data internally, and how does it tie into a strategic plan? Second, the what. What variables should we be asking? Race-based data or additional variables? From whom should we collect the data? Third, the how. How do we build trust and encourage participation from our registrants? I transcribed the sessions and used the thematic analysis to analyze the focus group data. The major themes included a need for knowledge. We don't have existing data on the demographics of our registrants beyond basic information that we collect at registration. In order to make data-informed decisions, we need more information. The objective informs the method. What type of data we collect and from whom depends on why we're conducting this work and how we plan to use the data. Meaningful application of data. This work cannot be performative and done for the sake of checking off boxes. Lastly, our leadership team identified the importance of system partner engagement and collaboration. Early into the project, the external DEI consultant that we worked with identified the importance of community partnerships and engaging with Indigenous and Black nurses throughout the process. We started with Indigenous and Black nurses, recognizing the historical and ongoing barriers that they face. Some of the things that we collaborated on included developing the survey. We sought input to strive towards harm reduction and cultural safety in collecting identity-based data. Our Indigenous partner flagged the importance of Indigenous data sovereignty, the idea that Indigenous people have the collective right to their own data. For example, OCAP is a set of First Nations data governance principles, which stands for ownership, control, access, and possession. We also collaborated on the interpretation of findings. We shared our findings with community partners, and they provided the interpretation of the results through the lens of their lived and professional experience. When we first set out to develop relationships with community partners, we had some initial challenges. I started off by cold emailing potential groups to collaborate with us, but we found that we did not have a lot of success until a mutual contact made introductions on our behalf. We also learned that building trust takes time. During the initial meetings, we simply listened. We listened to the inequities, the barriers, and challenges that nurses face in their practice before any conversations around the census began. While we did not sign any formal agreements, we created a terms of reference with the Black nurses groups that we worked with, which they also provided feedback on. This document describes the purpose of the partnership, topics around our planned meetings, and the honorarium that we would provide for individuals contributing their time and expertise. The terms of reference did not apply to our Indigenous partners, and we engaged with them differently. What might work with one group may not work with another, and there is no blanket approach. The working principles of our relationship included collaboration. We took the approach of let's work together to solve this problem, the problem being a lack of data being collected systematically. Transparency meant that we would provide regular updates outside of our meetings to share how the project was progressing. If there were recommendations made to us that we did not implement, we would share why and invite a dialogue. Reciprocity meant that the relationships would be mutually beneficial. So how do we develop the survey? Rather than reinventing the wheel, we adapted existing data collection standards and questions. We had 3 selection criteria when shortlisting the sources for our identity-based questions. First, we looked for sources developed within a local context, preferably in Ontario, but we are open to pan-Canadian sources as well. We looked for sources that were recent, developed within the last 5 years, recognizing that language is dynamic and that preferred terminology around identities evolve over time. Lastly, we sought out sources that included their own community consultations. This chart here summarizes the source of our identity questions. Indigenous identity came from the voluntary self-identification tool from the Indigenous Primary Healthcare Council. The question on ethnicity came from the Government of Ontario's Anti-Racism Directorate. Race, gender identity, and disability came from the City of Toronto's Data for Equity guidelines. Sexual orientation came from the Measuring Health Equity Updated Core Questions. And lastly, the option set for the questions on languages of nursing care and employer location came from StatsCan's census. Despite using pre-established questions and standards, we still had some differing perspectives on these questions during our internal and external consultations. Based on this feedback, we made slight modifications. However, going back to the point, language is ever-changing. In addition, the way a certain group identifies can vary widely within that group. The bottom line here is that perfect consensus is unlikely when seeking feedback on identity-based questions. When we first conceptualized the survey, identity-based data was on the table, but the idea of incorporating experiential questions came later. However, support for including questions on nurses' experiences in their practice was mixed, due to concerns of this being out of our regulatory scope. We put forth the following rationale. We know that systemic racism and discrimination exist, and the nursing system is not exempt. We also know that experiences can differ widely depending on your identity. So collecting identity data without asking about experiences felt performative and disingenuous. By also asking about registrants' experiences, we can identify who is experiencing inequities, to look inward into our own processes, and to start a conversation with our system partners. Ultimately, we proceeded to collect 2 types of experience data. The first type within C&O with processes such as registration and professional conduct, and in registrants' nursing practice with racism, discrimination, and harassment. For the first administration, we opted for a more conservative approach. The benefit of a voluntary data collection is that it gives registrants a choice. On the flip side, it also does not guarantee any sort of response rate. We collected data so that the final data set was anonymized. The benefit of this is a lower risk data collection because respondents' survey data cannot be linked to other C&O sources. On the other hand, this is a downside from a data utility perspective. It can severely limit what we can and cannot do. In fact, we have to re-ask data that we already collect upon annual renewal. For example, we know where nurses work, but we have to collect this data again because we can't link renewal data, or in fact, any C&O data to these survey responses. The dataset is anonymized, but not truly anonymous because we deployed unique links. We developed a process of creating 200,000 unique URLs, one for each nurse and a few extra. This was generated with a hashing algorithm to create an alphanumerical string. We then enlisted the help of another team at C&O to assign each URL to a registrant. This kept us blind to who was sent which link. After the emails were sent out, the list defining who was sent what was deleted. But because the linkage between these unique URLs and who they were sent to existed at a point in time, we cannot say that the dataset is anonymous. Why do we do this? The unique links act as a one-time password. If the survey included a record that did not match one of the 200,000 strings that we generated, we excluded the response. This was done to balance privacy without compromising data integrity. That is, it is a method of validating the responses. For example, if the link was posted in an online venue and we received an influx of responses, or somehow the survey was targeted by a survey bot, then this gives us a mechanism to remove these spam responses. For the sake of illustration, suppose ABC123 was one of the alphanumerical strings that we generated. If the dataset included a record tagged with ABC123, we would know that it was completed using a link that we sent out. If, for instance, we received a response tagged with DEF456, and we knew that this was not an alphanumerical string that we generated, then we would be able to filter out this record. At CNO, approximately 1.5% of our membership prefers a French correspondence from us. During the first administration, we administered an English-only survey. Translations are difficult. It's not a matter of getting a word-by-word equivalent in French, but preserving the intended meaning within the local context. For example, we know there are even some differences between the French spoken in France and the French spoken in Canada. Translations of DEI language adds an extra level of complexity. The best practice would be engaging with a Francophone working group to ensure that the survey was translated appropriately. Unfortunately, we were working with some time constraints, so we were not able to do this for the first administration. Since deployment, we've received feedback from French registrants urging us to provide a French translation. Our recommendation is building in the time necessary for translations. The first thing a nurse would see when they click their survey link was a use and disclosure statement, which was developed by our colleagues in information management and privacy. This describes the purpose of data collection, how data will be used, specifically that we will only report data in aggregate, that we may cross-tabulate across variables collected through the census, and that data suppression may be applied. Data suppression is done to protect the privacy of individuals when there are small sample sizes, because specific combinations of information can be potentially identifying. We further describe with whom data may be shared, that is, system partners in nursing. While our Indigenous data governance framework is being developed, we built in clauses that sharing of Indigenous identity data will be subject to an Indigenous-led governance committee. Lastly, I will mention that only the core project team has access to the raw record level data, and this is not accessible to the rest of the college. So to begin, everybody saw the use and disclosure statement. At the bottom, there was a statement, I understand and would like to proceed to the survey. Starting off with the yes branch on top, if respondents clicked yes, then they were brought to an advisory. This was a heads up to nurses to let them know that the survey would ask them about their experiences with discrimination, which may be painful or difficult. We linked a webpage from the Canadian Psychological Association on traumatic stress as a resource to support emotional and mental well-being. We also noted that respondents could stop and resume at any time. Moving on to the no branch at the bottom. If respondents clicked no, we asked them, would you like to tell us why you opted out of participating? And from here, we gained some insights. There was a subset of nurses who believed they were ineligible to participate because they were retired or in the non-practicing class. And based on the name of the survey, Workforce Census, they believe that since they were no longer part of the nursing workforce, they should not participate. So this was a learning for us that the next time we do this, we should clarify in our messaging that if you receive this email, then you're eligible to participate. Some nurses expressed privacy concerns that they did not want their data to be shared externally, and other nurses also told us that they did not trust CNO or they felt like participating would not make a difference. This slide here shows a timeline of our implementation and launch. 2 weeks before launch, we notified all registrants eligible to participate of the upcoming survey. We then launched the survey with unique links. 1 week later, we sent out a reminder email to everybody to let them know that we're still collecting data. 3 weeks after launch, we sent out a second reminder email, and this again went out to everybody regardless of whether or not they had already completed the survey. 4 weeks after launch, we closed the survey. The largest professional nursing association in Ontario with 52,000 members amplified our message by sending out emails to encourage their own membership to participate on these census. There were a couple of lessons we learned around emailing. First, make sure the system you use, whatever it is, has the capacity to handle the large volume of emails. For example, Outlook's daily sending limit is 10,000, so a large volume of email typically requires a specialized bulk emailing platform. During this time frame, we sent out 800,000 census-related emails on top of the existing communications coming out of the college. As a result, we unknowingly exceeded our email limit, and the census emails actually stalled during launch. They stopped sending until we upgraded the subscription tier with the email campaign software that we used. Lastly, the rate of outbound emails is throttled as a spam detection prevention mechanism. So it took over 2 days at every time point that we sent out an email for 200,000 emails to go out. Communications took the lead on promoting the survey leading up to launch with multiple initiatives. The census was mentioned in C&O's newsletter to nurses. They also coordinated a video from the Director of Research and Analytics, speaking to why nurses should participate. We have insight from our comms team that videos with real people tend to get the most engagement on social media. We shared promotional materials with community partners if they wish to distribute them within their own networks. And lastly, comms reached out to their own media contacts. Leading up to launch, we had an operational working group composed of leadership across the college. Following launch and leading up to release of the first report, we proceeded with a more agile core working group. Other departments that were not represented in the working group also assisted. For example, IT with coordinating the email campaign, finance with processing the honoraria payment for community partners. I also reached out to a sample of staff across the college who are nurses for their feedback on the survey. Overall, the census was a cross-organizational collaborative effort, and as a token of appreciation, we hosted a celebratory lunch. Lastly, I want to highlight that the process takes time. It took over 2 years from project inception to publishing our first set of findings. We sought feedback, internal and external. It also takes time to coordinate meetings with community partners because in our case, they were practicing nursing leaders across different groups and many institutions. We had ongoing conversations as feedback can be iterative versus one and done. On a concluding note, I wanted to say that build in extra time needed to do this work, especially if you are consulting broadly. So thank you again, and I will now turn it over to Niels.
Thank you, April, for the detailed overview of the development and the implementation of the survey. I'm now going to go over some of the findings from the survey. So for the full report and findings, please go to cno.org, the nursing statistics, and the workforce census. So before we jump into findings, I want to go over the representativeness of the survey. This is something that we had the luxury of being able to do to examine because we had our enterprise data available as a comparator. So most surveys like this don't have the population demographics to compare against. So we thought it was important to examine. I want to remind everyone, though, because the survey was anonymized and not linkable, we needed to collect this information a second time. So we already had it collected from annual renewal and registration, but we needed to collect it again a second time on the survey. So the column on your right is the survey data, and the column in the middle is based on our internal data. You'll see there are some differences between the two. So our data is not perfectly representative, which is something we want to keep in mind as we interpret the findings. One way to adjust for not having data that is representative is to weight the data. So that's a statistical technique that allows you to mathematically adjust your data to make it more representative. So instead of reporting your true sample proportions, you can report adjusted proportions instead. We made a deliberate decision not to weight the data in this first iteration of our report. We wanted to take this in as a finding in and of itself, the fact that the survey responses were not perfectly representative of our population data, because it speaks to where we may need to do more work in terms of our outreach. If certain groups were overrepresented or underrepresented, we wanted to highlight that. We also don't know the true population demographics for these new variables like gender identity, race, disability, things that we've not collected in the past, and we didn't want to introduce new bias. So it's not to say that we can't do it in the future. It's something we can do. We can weight the data in future reports or publications, but in this iteration, we are looking at unweighted proportions. So these findings do not necessarily reflect the entire nursing population perfectly, but they instead reflect the survey responses. So focusing on some of the variables, we can see that location of education is not perfectly representative. So in the right-hand column, again, we can see that of the survey responses, 90.9% were educated domestically or DENs, and 9% were IENs or internationally educated, compared to our overall CNO population, which is 84% DENs compared to 15% IENs. And going forward, you'll sort of note this color combination where yellow denotes underrepresented and green denotes overrepresented. So our survey was slightly overrepresented in terms of domestically educated nurses and underrepresented in terms of IENs. We also see something similar across nurse types. So NPs were slightly overrepresented at 4% compared to 2.7%. RNs overrepresented at 68.6% compared to 65.6%, and RPNs were slightly underrepresented at 27.3% compared to 31.7% of the general population. So next, we'll look at some identity highlights, identity data from the respondents of our survey. So looking at Indigenous identity, 2.3% of our survey respondents identified as Indigenous. So this would be First Nations, Inuit, or Métis. 94.3% did not identify as Indigenous, followed by prefer not to answer at 2.5% and don't know at 0.9%. We also looked at race. 64.4% of our survey respondents identified as white, which was followed by South Asian at 8.8%, Southeast Asian at 7.6%, and Black at 6.8%. Looking at gender identity, we saw that 90.8% of our respondents identified as a woman, 7.5% identified as a man, and less than 1% identified as either a trans man, trans woman, gender non-binary, or another gender. We also looked at sexual orientation. 76.1% of our respondents identified as straight or heterosexual, followed by asexual at 4.1%, bisexual at 3.2%, multiple categories at 1.6%, and gay at 1.2%. You will notice that we had a large response in the prefer not to answer category at 11.5%. So this was by far the highest prefer not to answer response across any identity variable, indicating that nurses seem to be less comfortable sharing this information with us, the regulator, than other demographics. We also looked at disability. 84% of our respondents identified as not having a disability. 12.4 responded indicating that they did have a disability. 1.4% indicated they did not know, and 2.3% preferred not to answer. In this next section, we'll look at intersectional data. So this is looking at those newly collected identity variables across other data. One thing we looked at was location of education across our identity variables. So you can see that across the entire survey, 91% of respondents were domestically educated, or DENs, compared to 9.1% who indicated they were internationally trained. So that's the green line at the top. But we can now look at location of education across these other variables on the left. So gender identity, nurse type, sexual orientation, disability, and race. So looking at men specifically, compared to the general population or the total survey responses, only 85% indicated they were domestically educated and 14% indicated they were IENs. So it looks like men are more likely to be IENs than women. We also see that in our general sort of population data at CNO, that men are more likely to be IENs. So that also speaks to the reliability of this data set. We see the same thing across racial categories. Almost 40% of Southeast Asian and 35% of South Asian respondents were IENs. So we see a high representation of IENs in the South Asian and Southeast Asian population, which matches what we know about the majority of IENs, about where they're educated and where most new IENs are often coming from as well, which is India and the Philippines. We also looked across employment sectors. So again, at the top green line, you can see that of our survey respondents, 22% indicated that they were employed in the community sector, 55% in hospitals, 14.6% in long-term care, and 8.3% in the other sector, which is just a catch-all for anything that doesn't fall into those three categories. That's a similar distribution to what we see in our employment and our renewal data. Again, speaking to the sort of validity and reliability of this data set. But when we look across other variables, we can see some differences. So looking across gender identity, for example, we can see that those reporting, those who identified as another gender other than man or woman, were more likely to be employed in the community at 36%, but underrepresented in the hospital sector at 40.9%. Men, on the other hand, were underrepresented in the community at 14.1%, and overrepresented in the hospital at 63.7%. The same thing we can see with IENs. We can see that they're underrepresented in the community, overrepresented in hospital and long-term care, and underrepresented in the other sector. Similarly, we saw differences across race. Black nurses were overrepresented in long-term care. South Asian nurses were overrepresented in long-term care as well, and underrepresented in the community and other. And similarly, Southeast Asian nurses underrepresented in the community, overrepresented in long-term care, and underrepresented in the other sector. Last, we'll take a look at representation across leadership roles. So looking at that top green line again, we can see that of the total survey responses, 7.7% of respondents indicated they were in a leadership role or a management role, and 92.3% indicated they were not. Again, we can look at these distributions across our other identity variables to see if there's disproportionalities. So looking across race, we can see there are differences compared to the total nursing population. 9% of Arab, Middle Eastern, or West Asian nurses indicated they were in a management role, so they were overrepresented. Similarly, 9.1% of white respondents indicated they were in a management role or in a leadership position, again, overrepresented. On the other hand, Black nurses, East Asian, Latin American, South Asian, and Southeast Asian nurses all were underrepresented in leadership roles. Black nurses at 5.8%, East Asian at 6.2%, Latin American at 4.9%, South Asian at 4.3%, and Southeast Asian at 3.2%. Now, of course, there are some compounding variables here like education and experience. So we know that nurses who have further education or more years of experience are more likely to be in leadership roles. So in the report, we did stratify these results across years of experience. So only looking at those nurses who had at least 10 years of experience, and we still did see some differences across racial categories. So finally, in terms of next steps, we will be publishing a second report about the experiences of nurses with CNO and racism and discrimination in their practice. It will be available in hopefully early 2025. We will continue to work collaboratively with our system partners in the interpretation and the development of the next report and in future iterations of this work. And finally, we will continue to reflect upon our experience and learnings in preparation for the next administration. Thank you for listening, and please don't hesitate to reach out to April or myself if you have any other questions. Thank you.